You're listening to the ReThink Health podcast, hosted by Dr. Marius Geanta and powered by the Center for Innovation in Medicine, a European research and innovation organization. Through this podcast and the ideas expressed by our guests, we want to build forward better and to set the stage for the European Health Union, one in which the Eastern voice is also heard.
So, hello everybody and welcome to the ReThink Health podcast. My name is Marius Geanta. I'm a medical doctor and head of the Center for Innovation in Medicine. And it's my pleasure to present you my guest, Fatima Mechta-Grigoriou, who is research director at INSERM in France and as well has an affiliation at Institut Curie in Paris as director of Stress and Cancer Laboratory, coordinator of the Breast Cancer Scientific and Medical Program, and scientific director of the Canceropole Ile-de-France. Thank you so much, Fatima, for joining us for this discussion. It's not so difficult to identify the main topic of our discussion will be around breast cancer, and this in the context of the publication of your study highlighted was one of the most important researchers presented this year at the American Cancer Research Association National Annual Congress in April this year. But let's start with the beginning. And of course, if we discuss about breast cancer, is not so correct in terms of biology. It's not just one disease. How do you see after so many years of research? How do you see actually now the breast cancer?
Yeah, first, Marius, thank you very much for this invitation. I'm really glad to be with you today to discuss about these important topics on breast cancer. And indeed, as you mentioned, breast cancer represents an heterogeneous pathology. There is the most common heterogeneity, which can be detected in several clone cells, such as including the in situ versus invasive features of a cancer, whether it's localized aspects and restricted to the primary tumor or its dissemination to the distant sites, including the axillary lymph nodes or the distant metastases. And there are many different, features, physiological features, which are already and well known and being involved in this heterogeneity in the pathology. But in addition to that, and to these, physiological and clinical heterogeneity, clinicians and biologists have also now identified different molecular subtypes of breast cancer. And these molecular breast cancer subtypes have been identified based on the expression of several receptors, which are located at the surface of cancer cells. And by this way, the clinicians define the luminal breast cancer subtype expressing the hormonal receptors, which include both the estrogen and progesterone receptors. This is one class of breast cancer subtype. But the clinicians also identified the HR2 breast cancer subtype, which is characterized by the amplification of the RB2 oncogene, and which lead to the overexpression of the HR2 protein at the surface of the cancer cells. And the clinicians finally identified a third subgroup of patients who are referred as the triple negative breast cancer patients, because these patients do not express hormonal receptors on the one hand, and they are not amplified for the RB2 oncogene on the other hand. Thus, these three main molecular subtypes have been identified in breast cancer: the luminal breast cancer, the HR2 breast cancer, and the triple negative breast cancer patients. Just the luminal breast cancer patients represent the majority of breast cancer patients with around 70% of cases, and the HR2 and triple negative breast cancer around 15% cases each. And as you can see, a wide heterogeneous pathology in breast cancer.
And going forward, you mentioned the clinicians, and based on these, let's say, findings and classification, actually the treatment, the therapy of the breast cancer become more and more, let's say, stratified or even personalized, with a lot of treatments based on estrogen receptor or progesterone receptor or HER2, including some new developments highlighted at ASCO this year. So, in other words, and I think this is one of the causes for the increase of survival even in the metastatic cases of breast cancer, was based or due to this very, very good understanding. But as you mentioned, we have this triple negative breast cancer with a lot of challenges and with a lot of expectations, some of them coming from the field of immunotherapies. We know some studies that try to find value for different immunotherapies for this type of triple negative cancer. Could you refer to this specific type of cancer more details, and maybe to go to your research as well?
Yeah, indeed. As you mentioned, the breast cancer patients now are now treated based, at least on the molecular classification that I just mentioned before rapidly. And then the luminal breast cancer patients are and based on the expression of hormonal receptors at the surface of the cancer cells, and the luminal breast cancer patients receive hormonal therapy, which target these receptors and inhibit the downstream signaling pathways. The HER2 breast cancer patients also benefit from a targeted therapy with the development of anti-HER2 antibodies, targeting then the HER2 protein, which accumulate at the surface of the cancer cell of these patients. And then, as you say, the triple negative breast cancer patients are treated by chemotherapy, mainly by cycles of both adriamycin and cyclophosphamide, followed by cycles of taxane. But indeed, as you mentioned, these patients could not benefit from targeted therapies as they do not express either the hormonal receptors or the HER2 receptor. So there is indeed here a clear medical need and for these patients. And indeed, recently, one of the most important and interesting new targeting therapy, which appears for this patient, correspond to the immunotherapy. And then one thing that we should mention here is that what I discussed before was really restricted to the cancer cells.
Yeah.
But then one thing that we need now to consider is the tumor microenvironment. And heterogeneity is not only restricted to cancer cells, but also concerns the cells of the tumor microenvironment. And meaning these cells which do not exhibit any genetic alteration as the cancer cells, but still these cells directly participate to the tumor development and metastatic spread. And they are really modified by the cancer cell and they promote cancer cell growth and dissemination. Then this is a strong improvement in the treatment of this cancer, because we can indeed now have a new strategy to target these populations of cells. And indeed, and in particular in triple negative breast cancer patients, because now we know that tumors of these triple negative breast cancer patients are more infiltrated by immune cells than any other breast cancer types. Then these patients are first expected to better respond to immunotherapy. And immunotherapy and new therapies, which aim to really wake up the immune system to help the organisms to eliminate these cancer cells. And as often the immune system is partially inhibited in cancer patients, and then immunotherapies aim to really awake this immune system and to increase the immune system efficacy. And as you mentioned, there are now a strategy of using immunotherapy and applying immunotherapy to triple negative breast cancer patients. In particular, one immunotherapy targeting signaling pathways involving PD-1 and PD-L1 signaling pathway. And this therapy clearly gives some positive response to triple-negative breast cancer patients.
So to complicated things, you mentioned that indeed we refer to the cancer cell when we discuss about estrogen receptor, progesterone receptor, HER2, and so on. Now with the PDL1 and PD1, we refer to the, let's say, immune system, parts of the immune system. And you mentioned as well the microenvironment and how important it is actually to look to other type of cells, part of this microenvironment. So that's why this is the reason I said that the landscape is even more complicated. So it's not enough to look to the cancer cells. It's not enough to look even to the immune system, different components of it, but also to take into consideration the microenvironment. Let's explain a bit what the microenvironment means, what type of cells are there, and how these cells actually interact with the immune system on one side and on the other side with the cancer cells.
Yes, this is really something which is important indeed, as you mentioned, because we have seen that indeed we are really able to target cancer cells, but most probably it's not sufficient. We know now that indeed trying to awake the immune system by trying to really treat patients with immunotherapies, it's a very good point, but we have also some patients who we know already that some patients will not answer to this therapy or perhaps will develop acquired resistance to these treatments. And then another type of cells, which is one of the most abundant cell types present in tumors, which are called the fibroblasts. These cells are not yet targeted therapeutically. But while they are very abundant and they are really participating in the tumor growth and tumor escape and tumor dissemination, and then we know that indeed some types of these cells are really interacting with cancer cells. And we know also that some cells which belong to these fibroblasts, indeed, they also directly inhibit the immune system. And we know that we need absolutely to take into account the heterogeneity of these fibroblasts. And as for the immune system, we have good guys, we have bad guys in fibroblasts, and then we need to really convert the bad guys into good guys just to really be able to eliminate the cells which prevent the efficiency of the immunotherapy, because we detected some fibroblasts which are able to inhibit immunotherapies, and some of the cells which establish a dialogue with cancer cells and promote their growth and their dissemination into the body.
Yeah, just to clarify, because I think it's very important, and your research presented at AACR for me was, enlightening, because I have seen the fibroblasts for the first time actually in connection with in such a strong connection actually with the breast cancer, and you mentioned that the fibroblasts are in charge, let's say, with the tumor increase in volume, with the development, within metastasis. Is that correct?
Yes.
So we should consider somehow to target them from the early stages of the breast cancer and not looking just to the advanced stages, right? To the metastasis.
Yeah, that's exactly the point. In fact, we need absolutely to understand how these fibroblasts and these, let's say, bad guys of a fibroblast really appear in tumors to be more able to target them. And we need to target them as soon as they appear in the tumors. And as you mentioned, indeed, you can have, and among these different classification of the different breast cancer patients, we do not have the same type of fibroblast within each of these breast cancer types, from an in situ to an invasive tumors, and in addition from primary tumors and the metastatic at the metastatic site. Then we need absolutely to really understand how these fibroblasts appear, what is the crosstalk with the cancer cells, because that's the cancer cells which promote the appearance of the bad guys of fibroblasts. And as soon as they are here, we need absolutely to target these cells, either by trying to eliminate them or by converting them from, let's say, a very deleterious aspects to the patients to a more beneficial cell, because they are not exhibiting any genetic alteration. Then perhaps we can play with their plasticity.
Which is, I found very interesting, is that we know that the cancer cells are different in the primary tumor than are in the metastases. And you just said the same thing for fibroblasts that are different. So we can expect that, maybe as well for other type of cells that might be in the microenvironment to have the same behavior maybe and to play a role. Do you have some other additional data regarding other type of cells?
Yeah, we are really going into a high resolution in the better understanding of the heterogeneity of these different fibroblastic populations. And we know now that indeed, when we detect some populations, the patients will have a higher risk of distant metastasis, even at long term after the treatment. Or we know already that this patient at time of diagnosis will not answer properly to immunotherapies. And we need absolutely to take this heterogeneity into account. We need absolutely to really introduce in the clinical settings staining for these different fibroblasts to establish at the time of diagnosis the proportion of these different populations, either in the tumor or in the metastatic sites, because indeed, as you said, we know now that some of these populations, and in particular the bad guys, accumulate at the metastatic sites, even if we do not detect a lot in the primary tumors. And this is something which is really important. And then we need to treat this patient by considering the metastatic sites and not only the primary tumors.
So we should look very, very carefully. You mentioned this high definition possibility based on technologies you have, single cell omics and so on. So we have this opportunity to look in very much detail, actually, from the beginning at the case of breast cancer. And I have seen some data recently that shows, we consider that 5 years it's enough to say for a person that it's okay after the diagnosis. If is no recurrence, it's fine. But for breast cancer, there is a percentage, and this is not a small one, that actually have a recurrence after 7 years, 10 years, 12 years, 20 years. So maybe it's too early to say more about this. But if you will be able to identify these bad guys that might be fibroblasts or other type of cells, or let's say indicators from the beginning, we'll be able to provide a really personalized follow-up of the patient, right?
Yeah, exactly. In the cases that you are referring to, I think that it's more cancer cells which can be dormant, and indeed which can be, unfortunately, and from a signal that we don't know yet, can be awake after many years of being silenced within the body. And but among that, and in addition to this cancer cell phenotype, which is really a dormant phenotype that need to be analyzed really deeply, indeed, the fibroblasts can also promote this type of, a way to promote the dormancy of the cancer cells. This is the first thing. And the second thing is that indeed we highlighted in luminal breast cancer that a few percentage, it was quite few, but still 5 to 10% of patients who exhibit a high content of our fibroblasts that I call bad guys, then these fibroblasts, if they are present in the primary tumor, the patients exhibit a very high risk of developing very late after the treatment, recurrence and relapse. Then indeed, we need absolutely to take all these different populations of cells into consideration.
And this actually is a main challenge for the, let's say, medical practice, oncology practice, maybe for some oncology dogma. You're a researcher mainly. So how do you see this wave of innovations? Because on one side, the breast cancers look like very good examples to show what early detection and screening and all these biomarkers or the targeted therapies, immunotherapies, the value of all this innovation, I think for breast cancer is a very, very strong argument. It's a very good examples to show. But discussing with you, it's clear that there are a lot of unknowns regarding the breast cancer. How do you see this new wave of research in breast cancer and maybe the implementation in the clinical practice?
Yeah, it's a very important point here that indeed we will not be able to perform single cell analysis for all patients or even spatial transcriptomics that we are now doing in research in clinical practice. This is clear. But now we have defined, based on this analysis, we have defined some markers and some tools that can be very useful to and quite simple to establish in clinical routine. And then we can take these different markers to establish the right diagnosis of a patient and to have, for instance, a follow-up, which will be longer for patients who exhibit what I said, this high level of bad guys fibroblasts into the primary tumors or into the lymph nodes. And this is quite possible. For instance, I developed in close collaboration here with clinicians, Dr. François Clément Bidard and Anne-Vincent Salomon at Curie, with the help of some other researchers, including Irène Buvin. We developed a clinical trial in which we will label these fibroblasts by using PET-CT and what is called FAPI, which is a new radio tracer to monitor the content of these fibroblasts within the body. We will be able to see all these fibroblasts, activated fibroblasts, bad guy fibroblasts into all the bodies. And we will be able to classify the patients and to really highlight the patients with high FAPI staining, meaning high bad guys fibroblast content in their primary tumors as well as in their metastases. And based on that, we can adapt the treatment and potentially, of course, the follow-up, just to be sure that this patient will not relapse.
So we can expect for maybe next year the first data from your clinical trials, because yes. I found very interesting to put together other technologies like PET-CT and this radio tracer in order to actually to identify the content of the fibroblast, right?
And we will compare that. Sorry, just to finish, we will compare that with the classic FDG PET-CT that is commonly used in routine. And what we think is that the metastasis within the brain will be more visible with a FAPI compared to the FDG. Then that's why I think that it could be very interesting to see what will be the comparison to detect the fibroblast with a FAPI and to detect perhaps and to compare with a classic PET-CT, which is commonly used in clinical practice.
Yes, a better and a sooner actually identification, right, of the potential
Yes.
changes. Yes, which is very important, especially for the brain metastasis. So I have one final question for you, Fatima, because you already with your research, with these new insights from your clinical trial, you already are, let's say, in the future, in the avant-garde of the breast cancer. But what we should expect in, let's say, 5 years, maybe 10 years, in this field of breast cancer, you being in the middle of the high-level research worldwide. So,
What now? We have identified this population, for instance, by performing single-cell RNA sequencing. Then, just to explain to people, this means that we identify for each cell the expression of, let's say, all the genes within each cell, within all the cells within the tumor. And now, another dimension which is important is the spatial localization of each of these cells within the tumor. And then, just by performing this analysis, detecting the expression of each gene within each cell, within each tumor of each patient, we are really able to localize precisely different niches, meaning different modules of cells which are close together, while some others are far away. And then this is interesting because we localize some specific fibroblasts with some specific cancer cells, with some specific macrophages and some specific T cells. And we know that all these cells are interacting together. And by performing analysis thanks to artificial intelligence, we can now recapitulate the interaction between all these cells all together. When we better understand, based on this expression of all these genes and their localization within the tumor, we better understand the crosstalk between these different cell types. And what we expect is to better predict the relapse of the patients and to better understand the development of metastasis and resistance to treatment, because this is exactly where we need to go in clinics.
Sounds fascinating, because this, let's say, 3D network of different cells and interactions and the way different cells communicate, it's similar with the studies we have seen in the sociology related to COVID-19 and the personal networks of the individuals. So it's fascinating actually to see how actually the science is moving forward using quite the same, let's say, type of thinking, quite the same approach. And I'm sure, Fatima, that we'll have the chance to at least to discuss about this. Why not to work in research projects on this topic. So thank you so much for accepting our invitation to the podcast, and we are looking forward for your future scientific communication and projects. Thank you so much.
Thank you very much, Marius. Thank you.
You listen to the ReThink Health podcast, hosted by Dr. Marius Geanta and powered by the Center for Innovation in Medicine, a European research and innovation organization with interest in visionary health policies and civil society education. Through this podcast and the ideas expressed by our guests, we want to build forward better and to set the stage for the European Health Union, one in which the Eastern voice is also heard. The war in Ukraine, overlapping with the health crisis caused by the pandemic, changed our lives overnight, once again. We are all rediscovering the fear and the uncertainties of just 2 years ago, from the first days of the pandemic. We have a health crisis, but it is completely different from the pandemic health crisis. Naturally, not only health, but individual safety, from all points of view, has become and is now our main concern. At the Center for Innovation in Medicine, we are aware not only that we have not returned to pre-pandemic normalcy, but that we have entered the new post-pandemic normalcy. We are experiencing a new reality. Science and innovation do not stop because the war has begun. and nor will we.